Thanks everyone for joining us. Today, our board from the American Lipedema Association is going to give you a recap of what we experienced at the Lipedema World Congress, sponsored by the Lipedema World Association. Did I get that right, Susan?
It's the Alliance, I think.
Alliance. Thank you.
Yeah, you're welcome.
So we had a 4-day gathering at the beginning of November. It was just a huge success. There were over 800 people there, with about a third, from the show of hands I saw, patients. So that was extremely thrilling. And from the patient perspective, hey, come on, little machine. We had, what we're going to do today. Great. So we're going to tell you who was there, um, give you a look into the presentations board members gave. Every board member who attended the Lipedema World Congress gave a presentation, at least one. Each of the board members who attended is going to give you some of their notable takeaways from the LWC. And then at the end, stay on, make sure you see that end slide. There is going to be a QR code so you can download the LWC abstract book. It's a PDF, it's over 200 pages, giving the high level outlines of what every presentation at the LWC was. And then you can look for more information. Not all of the studies that were at the LWC were published, but we'll give you a flavor for what we don't have in our takeaways. There's just so much information. So we'll go ahead and get started with who was there. These are all of the patient organizations, or at least the ones we all jotted down, that were at the LWC. So it's incredibly important for our patients to be involved with our researchers. And it was really a thrill getting to meet folks from Australia. Talk Lipedema is essentially from Scotland. Lipedema UK. Leo is Lipedema Italia. Abrali is a dynamite group from Brazil. The French group presented a couple of times. We had a great time hanging out with our Lipedema Canada colleagues. And you can see also that several of the Swedes and Norwegians and those from Denmark were also attending, folks from Portugal, Ireland. It was really a cross section of the entire world. So our next thing is jumping into the presentations we did. So this doesn't show everybody. Dr. Wright, I don't have a picture of all of us and you that I could put on this slide, but we were all there. That's Susan, Karina, Hiba, and myself. Hiba's not able to be with us. She is recovering from surgery. So we will jump in. And Susan, this will be you to start. So if you want to talk a little bit about what you and Hiba presented.
Yeah, so on the first day of the conference, Hiba and I were among a group of 7 or 8 different patient organization representatives that were asked to talk a little bit about what our organization is, why we formed, and then some of the activities that we've undertaken. And while we had a great time speaking, we also, all of us were in the room at the time, and we took tons of notes about things that we can learn from the other organizations that are doing different things that have been in existence for longer. For example, Talk Lipedema has been in existence now for 13 years, and Lipedema UK They are some of the founding members of the Lipedema World Alliance, and all of them were so incredibly kind and willing to share information with the other organizations, including educational materials and that sort of thing that Connie's been working on for our own organization, but also ideas about how they support their community. And so that was as much a learning session as it was a talking session. But this is one of the key slides that Hiba and I presented, talking about why we formed here in the United States. And for us, it was because there's a gap in the services being provided. We've got the Lipedema Foundation, which is obviously fantastic and doing such great work in funding research and leading research and that sort of thing. And then we also have a layer of a ton of social media influencers like myself, where I still do run legs like mine and that sort of thing. But a lot of people who are in the ALA also share their personal stories in social media. But a lot of times what that happens is it shares in our own circles, and it's not getting out to the medical community or people who don't happen to touch our circles. And so we really wanted to fill that gap and get the word out where we can influence the training that's happening in medical schools, awareness for existing providers, whether it's physicians, therapists. There's a whole gamut of folks that are already in practice and they're in their 30-year careers now that need to get the word out. So we wanted to fill that gap. And then we also wanted to fill the gap of providing advocacy services on behalf of the community as well. And that means as much as, advocating with insurance companies at a broad level, not for individual cases, but also advocating at the legislative levels as well. And we wanted to unite our voices to empower the folks in our organization to be able to do that. As we think about this a little bit longer term, and as I was speaking to the slide, one of the other things that we want to do to fill a gap is to provide a sense of community and support longer term for our ladies as we continue to grow and broaden our own scope too. So if I were going to present this slide in a couple of years, I hope I would have another layer to the pyramid kind of stuff there, right? That talks about providing a sense of support and community and that sort of thing. So we have a vision for the future, but we definitely, right now, we're trying to fill gaps that haven't been there in the past. And we feel like this was really well received. I'm watching my time here to make sure. I think I've got one
You're
more.
good.
The other thing that we noticed is a lot of the organizations that were speaking did not yet have recognition of the diagnosis codes in their country. I think only one of the 8 that spoke actually had gotten a code implemented in
Hmm.
their own country. And so a lot of us are in that same situation where we're just trying to get recognition of the disease, and understanding that on a global level helped us to form this sisterhood of we're all in this same struggle together. We may
Hmm.
have implemented different things, but we're all coming from the same place. So that's a little bit about what we talked about in our very first presentation, introducing the ALA. And it was a great start because we had our board members recognized there. And people then, for the rest of the Congress, were able to recognize the people representing you there in Rome. And that helped us to make connections throughout the rest of the weekend. So thank you for letting me kick off, and I will go ahead and mute myself back out. Thank you, Connie.
All right. So next up is Karina. So Karina, tell us a little bit about your presentation.
Thanks, Connie. So I came from a framework of how many of us have pretty much suffered with medical gaslighting for most of the time ever since puberty. So for many of us, this has been going on for decades. And making sure providers understand the mental health burden that lipedema poses, especially when the overall messaging is that you're just obese and you're not trying hard enough, or you're being flat out accused of lying. I brought up some components that are very frequently talked about in medical school, because you're probably wondering, why is there a zebra there? In medical school, a lot of professionals are trained, if it looks like a horse, it's a horse, it's not a zebra. So with that being said, that's kind of what happens. We have a lot of disparities among this community because we are dismissed often. And a lot of our other comorbidities are never even taken into consideration because they always just blame the obesity. Oh, you're having problems with your knees and your gait because you're overweight. When in reality, a lot of us have connective tissue disorders that go along with lipedema, such as hypermobile Ehlers-Danlos. And so there's a lot of factors that get missed because they just blatantly go, it's obesity. If you lose weight, all of the problems that you're experiencing, they'll all go away. I can't even tell you how many times myself personally that has been the messaging. I actually challenged the providers to really understand what it looks like to live in our shoes and what it feels like. And why don't you like strap some 20-pound weights onto your ankles and go throughout your day? Run with your kids, play, work, do that for a week if you could tolerate it, to give you a little bit of an understanding of what this is like, because you have legs often that feel like they're not yours and they're not working right. And as you gain more knowledge and basis with other people, and you're watching your peers mostly who do not have any of these vague problems that you do, and so often you're feeling that this is just in your head, this is just me. And it's not. There is a rationale for it. What I thought was fabulous is one of the plastic surgeons from Spain, later on, he kind of stood up and he's like, I wore compression. It was awful. So, and bravo for him, just to be like, yeah, it does suck. Because I think most of us can attest to that. And it's expensive. And you invest in something that often doesn't even fit right or actually can make things worse. And that can be very difficult as well. I think there's another thing in medical school gets talked about early on, is cura personalis. And it's, instead of looking at any one factor of the person, it is really important to take care of the person as a whole. We are not just lipedema. We are moms, sisters, wives, daughters who are carrying a huge amount of other responsibilities. So when providers are like, oh, just do, and you get compression and rebounding and 50 other things to just add on to our incredibly busy days. I put up a slide with a Google of, this is what an average day looks like for a working mom, with an entire page in a very small font that went the entire length of the page. And most people laughed because, as we all know, that is a very small fragment. So then when you're asking people now, on top of this, in order to take care of your overwhelming disease process, just add this. And so that way they understand there's a lot going on here. And the mental health support and burden that we have in managing this as best as we can is a true testament as to how strong we are as people. So with that being said, thank you very much for everybody who's joining and being here today, and just spread that word that, as we continue to grow, that we just keep sending our messaging out and connecting with others and educating everybody. Thanks.
Thanks, Karina. That's powerful. I'll go next. My presentation was not a talk, but rather a poster session. And posters are something that happen at academic conferences so that researchers who can't be fit into the schedule to do a speaking block can actually talk a little bit about their research. And I really looked at the fractured US healthcare system, and that's really what drove us at the ALA to get started in patient advocacy. There's over 1,100 health insurers. There's over 400 health systems. We don't have an ICD-10 code. There's also no requirements for electronic records sharing. There's no standards. So, for example, I have medical records at 5 or 6 different systems that it's almost impossible to have all of those brought into one place and shared across all of my providers. We are the patient-driven advocacy organization, ALA is, for the US. All we're here to do is advocate, and we're founded and staffed volunteer staff, by patients. As you can see, I kind of highlighted some of those fractured healthcare system information on the right-hand side of the poster, as well as some of our advocacy goals and successes. The amount of comments and information we got to the CDC during the comment period for the ICD-10 code this fall was amazing. And of course, we had our ALA advocacy training day. And as you can see, just that one training day really gave people confidence and competence in doing their own advocacy. And I know that we have promised to have that out on our website as a class. It's extraordinarily hard to contract a 6-hour training day into something that maybe takes an hour. So I'm still working on that. It's going to be coming. And I talked a little bit about some of our systemic challenges and next steps. Issues around no ICD-10 codes, around lack of medical education, really make it challenging in the US as compared to some of our benchmark countries where there is an awareness of lipedema as a legitimate chronic condition. So we're really excited about getting to work on those kinds of things in the next year. And finally, Dr. Wright, I'm going to turn this over to you. You've got 2 slides, so let me know when you want me to switch from one to the next. Dr. Wright, you might have to take yourself off mute.
I'm sorry. So one of my talks was about some original research I was sharing for the first time on the GLP-1 use in lipedema patients. And so looked at a couple core measures of lipedema symptoms, i.e., leg swelling and pain. And and we did find that the GLP-1 medication improved the leg swelling from an average of 5.4 to decreased to 3.6 out of 10. And that was, significant at a p-value of less than 5. And that's with a relatively, so we're only reporting data for a small, like a little over 30 research subjects. So that you can go to the next slide. And the other one was tenderness to touch, which also decreased while taking the GLP-1 medication for at least 6 weeks. And that was also, so it went from 4.9 to 3.7 out of 10. And that was on also significant, though at a 0.1 level. Yeah, that was one of my talks, and I just wanted to share that highlight.
Amazing highlight. I'm anxious to get to when you talk a little bit about your takeaways. So that is our next section today. Key insights from the Lipedema World Congress. Here's a shot of one of the sessions. You can see Dr. Wright there up on the podium. There were so many sessions, as you can imagine, with the abstract book being over 200 pages long. There were sessions every hour, often multiple sessions per hour in multiple rooms, multi-tracked conference. So there was a huge amount of information for us to take in. And even with the 5 of us there, we wouldn't have been able to cover everything. So what we're going to share with you are the things that really we're still thinking about as we come back from LWC, things we're excited about, seeing more research on, and likewise. So Susan, I'm going to call on you first, and here you go.
Thank you. I think that and a lot of us will probably say similar things. The one of the things that really stood out to me is that there were professionals there from a lot of medical facets. We heard folks that were, obviously therapists and surgeons, but we also saw a lot of researchers who had different specialties that were in the room. A lot of providers that were from different specialties too, and that was really exciting. Some of them came from countries where they might be the only provider in the country who is recognizing lipedema and treating patients and just trying to like drink in all of the information. So I thought that was really exciting. And then to see visually all of the patient groups. That one really excited me as well because, I had gone to Potsdam during the Lipedema World Congress in 2023. And yes, there were patient groups there, but they weren't as broadly represented as they were this year. And for
Mhm.
me, this collaboration, not only between different provider types and patient organizations, but between different patient organizations really excited me. It gave me hope that there's so much opportunity for research to continue in broad ways and hopefully someday find a treatment for lipedema, but also to find ways that patients can be supported globally. And I have this vision too of a patient in the States who maybe isn't getting the support that they need for whatever reason, being able to have a connection in another country that may have a similar experience and wants to share and make connections, across that way too. So I thought that that was really exciting. The other thing, which we're still a little bit tight-lipped on because we're watching this journal called Nature that I see somebody doing a doot 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 on the screen. Um, there's a journal called Nature, and one of the doctors, Dr. Philip Krupa from Germany, spoke on behalf of the Lipedema World Alliance when he was talking about this. But behind the scenes, the Alliance has been working on what's called the Global Consensus Document. And they have worked on it for a while now, where they have reached out to not only researchers, but providers and a couple of the patient organizations that were in the LWA prior to us. And they've been testing statements to find out how many people agree on certain things. And the reason why this is really important is because there are several things that the world hasn't yet agreed on so that they can then get to a global standard of care,
Mhm.
right? So one of the big announcements at the conference was here shortly, a global consensus document in the first version will be published in this Nature journal. And we check it every single day to see when it comes out so that we can, go through it line by line and then share some of the information that doctors globally have agreed on. Like some of
Mhm.
the questions they're asking are, is there really swelling in lipedema, for example? And, there are all kinds of questions that they're trying to just come across, right? Where if they can agree on it, then they can say, we can take that consensus document to our own physicians or to insurance companies or whatever and say, at a global level, doctors are agreeing on this, researchers are agreeing on this. You need to be paying for compression or pumps or whatever the treatment plan is, right? So that all leads to being able to standardize care and then standardize the way that patients are treated and the opportunities they have to be covered by their insurance companies. So I left with a ton of hope. That's what I'll end it with, a ton of hope for work in the future.
That's great. Thank you, Susan. And Karina, you will be next.
Okay. So to pretty much echo Susan's point, that global consensus is super important. Um, I think the other important factor of that is so there is an alignment within the communication and messaging towards patients. Because I feel like so many of us, we get bombarded with 800 different ways to Sunday of the best way to manage it. Or there is so much overwhelming amount of information that you just freeze
Mm.
and you're actually not knowing what to do. And because of all the previous history of the medical gaslighting, there is so much to be skeptical of or afraid of because of making things worse. So without
Mm,
having that research, I know for myself personally, there's a lot of treatments and therapies that I'm very gun shy of because I have had very poor outcomes with my lipedema because of things that I was told were going to help me. And within 6 months, I've gained 50, or 6 months, I've gained 50 pounds. And to, I think, many of us, that has happened and is very scary. There was a lot of case studies or anecdotal evidence. It would be great to see that kind of build out more to where we have
mm,
more research based on some of these conservative therapies. There was a lot of stuff about surgical and techniques and different ways of doing the surgeries, but I can tell you there was some presentations that were a case study with photographic showing of things that I was like jaw dropped. Like, really? That was conservative therapy of taping by a CLT in 4 months, and that person's legs reduced like it looked like they had surgery. I was floored by
mm,
some of the outcomes, but again, it's the one here, one there, and to be able to have it be reproducible,
mm.
um, to where it helps a lot of people, not just we've noticed this at in one or two places. Another takeaway that I had was the utilization of ultrasound for diagnosis. That I think really needs to get pushed. And that's something I would really love to see in the global consensus because it is affordable, it's reproducible. There are already metrics available that are definitive because I have had a lot of patients report to me that when they go to their providers, that's just an internet thing. Lipedema is not real.
Mm.
It is obesity. It's just an excuse. People are actually having this said to them by their providers, even though this has been something that we've known about for about 80 years. So I think having kind of a concrete, you can look at the information and without a shadow of a doubt, yeah, that's lipedema. Because as and myself being a nurse, I have used ultrasound many times to place IVs and I've used it on myself. And I can tell you there is a big difference in the way my skin looks versus somebody without it.
Mm.
So for me, that was something exciting to see. And I know a lot of it was, what was your favorite presentation? I didn't have a favorite presentation. My favorite thing was meeting people across the world who echoed so much validation,
Mhm.
um, and so much work. And to see 860 people from 30 different countries all working very, very hard to help people like us live better lives. That was the most impressive thing for me.
Totally. Thanks so much,
Thank
Karina.
you.
So, I will echo a little bit the future directions in lipedema research. I think that there were a lot of, there was essentially like a brainstorming session amongst patients and physicians and researchers and therapists. And I really found it fascinating to understand, what they wanted to see, what they were really excited about. And I also thought there were a lot of comments about really, multidisciplinary collaboration. I mean, we do a lot of our own case management. And I think that, as you've already heard, we have the consensus document, the global consensus document. We can really hopefully encourage, in particular, provider groups or physicians groups to talk with each other, maybe have, a patient coordinator who we can tap into. I mean, I think something like that would be just amazing. The other thing, the other session that this was a session that did really, really excite me was objective pain measurement in lipedema. There was a small case study that can be replicated into a larger study about pain and lipedema. And what is interesting is that because the hands and feet tend to be spared in lipedema, we actually have our own control in our own bodies between that and maybe our lipedema. So I was really excited to see that, excited to know that this study utilized some already existing measures, the pressure pain threshold, with the seat classification system, so that it is some standards that are already existing. It's a little bit like what Karina just said, that can be used, and the instrumentation that could be used in a primary care provider's office is not that expensive. I mean, my primary care provider has its own lab inside of it and does, does some of the x-rays there. Adding, a relatively small portable device to do objective pain measurement wouldn't be a problem for them. So that particular thing was really exciting. And then Dr. Karen Herbst did a session on mast cells and lipedema pathophysiology, which I thought was really interesting. She is looking to find a way to really detect mast cell activation with specific, again, repeatable, easy, inexpensive testing. It is actually something that I've sort of wondered myself if I have. I don't want to have to travel all the way to see Dr. Karen, but if this could be developed, again, it's something that could be easy external validation of things you think you might have. And these kind of um, standardized tests put into the hands of an educated primary care provider could really enhance our well-being, I think. And then Dr. Wright, you get to wrap up this section.
Yeah, so I mean, these are just some of my I looked in my notes, and I mean, these are things I knew before going, so this is not completely new to me, but I thought it was really, I just thought it was really important to share these insights because I think they're not well appreciated. One is there, as we know, there's EDS or Ehlers-Danlos syndrome is common in women with lipedema, and some have not full EDS, but just general hypermobility or hypermobility syndrome disorder. But they, in addition to being have stretchy skin and joints, they actually have hypertrophic or more fibrotic scarring. So that's kind of, I mean, I think that's something to really appreciate because it's certainly very common. Um, and then the interplay with lymphedema and lipedema or lymphatic function in lipedema, has been there since the first, in fact, when it was first described, back in 1940, 1939, 40. And and but and it's still about our understanding is still evolving, but about 75% of women with lipedema in this study by Dr. Campisi, I that's supposed to be Coronado Cam. It's Coronado Campisi is his name.
Uh,
I may have that may be my error.
we'll
Um,
fix it.
but he's in his study, he showed 75% have impaired lymphatic function
Mm,
via lymphoscintigraphy, which to me is very impressive because lymphoscintigraphy often you can have lymphatic impairment and have a normal lymphoscintigram. So even with so when you have lymphatic impairment showing up on a lymphoscintigraphy, you already have some. It's more than just a little bit. Um,
mm,
so let's see. And then you know, one thing that I thought, it bears emphasis was that so this is a lipedema is a subcutaneous adipose tissue disease. It affects it systemically. And while there are some in Europe who believe it only in the extremities, I believe it is also in the trunk. But also, typically, though, it manifests first in the legs, but about 70% show it in the arms. And so just some people, I think we need to bear this in mind when people say, well, I got my legs treated, now I see it in my arms. Well, it's not that it really metastasized to your arms. It was there all the time. It's just that perhaps perhaps you're now become more aware of it. We see this in veins a lot. Well, we'll have someone come with really bad veins on their one leg. We'll treat them, they'll be all better. And then they'll say, but now my other leg hurts. And I'm like, well, but they had the veins before, but they weren't appreciating them hurting before.
mm.
Or or sometimes people, if they progression, it can also progress, the disease can progress, especially associated with weight gain. So that's those are my three kind of points I wanted to um, kind of emphasize.
Yeah, that's great. Thanks so much. Now, I'm going to bring up the thank you slide so folks can take the survey and get the download for the abstract book. But do you guys have any questions for us?
We must have done a really great job.
I had the
I have a question.
opportunity.
Yeah.
Okay, yeah, take the question. I just had a comment.
I have a question. So I deal with I've massage practice in Redmond, Washington, and I treated lymphedema back in the 90s. Now I see a lot of lipedema people stumbling over my door wondering what to do. And what it seems to me, since the GLP-1 is working for them, and I agree that it's systemic, um, it looks to me sort of like there's a diabetic connection in the sense that people seem to hyperaccumulate, or it's almost like the liver and the kidneys just don't want to deal with certain things, and so they just shunt them into whichever overly stretchy fat pocket is available to put things in. And I think this is why I see people who reduce so quickly when they change their diet, or we get the lymphatic system siphoning faster. I just want to know, especially from the doctor, if you had thought along those lines at all, and if there's any research about the metabolism of the lipedema people.
Yeah, so that's a great question. Thank you for your question. Actually, I've an author on a couple publications about this. Um, so you know the so in so in general, your average lipedema patient is more metabolically healthy or more insulin sensitive than someone of a similar weight. Now, that said, everybody,
Interesting.
as we gain weight, becomes more insulin resistant. So, but this has the biology of subcutaneous fat is generally confers insulin sensitive. So it is more likely to take up, it's more insulin sensitive. It's more likely to take up um, uh, glucose in simple carbohydrates in response. So you're, I mean, it does weight and adipose accumulation does tend to go in those areas. And
Well,
so
and
that,
conversely, when people get liposuction, it seems like their bodies are reacting to sugars differently because there's sort of less triggering and less of a load. That's along the lines of what you just said, correct? Like if they're less obese or there are less fat cells, they are less insulin sensitive. Is that how that works?
well, so that's still controversial. There's a guy in my town who believes that, but I'm not sure yet that we're sure of what you're
Okay.
saying. It's possible. They do there. It does seem to certainly it does reducing the burden of adipose tissue in lipedema affected areas does seem to help women certainly not accumulate and maybe even metabolically. But we're not. I'm not 100% confident we can say that for sure.
Thank you, and I understand that you have limits inside of what you can say legally, right, medically. But I do see like on the ground on a narrative basis and suspect that the fat cells almost have their own cravings and their own desire to maintain them. It's weird, but follow with me, right? That the fatter someone is, the more the body wants to sustain that. I don't. It seems that's what's happening sometimes. So
Sure. Yeah, I agree
thank
with you.
you.
Tanya, did you have a question? Tanya Holloway?
I just sent it to Susan.
Okay.
That way, just in case it's not like, because like I said, it's not about the LWC. So if she wants to answer, cool, or we can take it, offline and
Let
discuss.
me
I'd
look and see if I can see it. I didn't see it pop
I
up.
I would like to add a couple more thoughts on this. Is
Please.
that it really is it really is a special. The meeting is special to see all these other people that care deeply about lipedema. Not just and it's so great, that people, patients and patient organizations, but also for our for the clinicians and researchers. It's very important that we have a place to meet and share some of it. Even what we shared highlights from talks, but so much of it is just also just the social sharing and tips, like that don't make it in talks. That's so if you ever get a chance, and we may have a chance, it may be coming to the U.S. In 2027. If you get a chance, and it works into your schedule, it'd be great. I would encourage everybody to try and attend.
Connie, I do have one thing to add. I don't
Yeah,
know
go
if
ahead.
were you going to make any announcements about the 2027 or anything like that? I don't want to steal the thunder.
No, that's what Dr. Wright just talked about.
Okay. Is there anything else? There was a question about next year as well. Is there anything there's nothing really we can share about 2026 at this point?
No,
No.
Yeah.
it's not set in stone about the U.S. We're still trying to work out how that may or may not come to be. So, but that it looks certainly that's where the talk is about right at this point.
I will make a note. A couple of people were talking about the QR code for the abstract book. There are links in that abstract book. Those links go to somewhere else in the PDF. They do not open externally. So if you see the title and it's got a link, you click that link and it takes you to the page where the full abstract is. All right. Any other questions?
Thank you very much for sharing
Oh.
those insights.